Numerous disorders and genetic variations may cause the co-manifestation of dystonia and ataxia, which can lead to considerable diagnostic uncertainty. Complicating this situation is a general lack of awareness of dystonia-ataxia syndromes, unlike the well-known dystonia Parkinsonism or dystonia myoclonus associations. A new comprehensive review article published in Movement Disorders Clinical Practice aims to increase this awareness. By proposing a series of clinico-radiological algorithms as well as a sequential diagnostic approach, the article can help clinicians identify the spectrum of disorders that present with both dystonia and ataxia, potentially enhancing diagnostic success. The algorithms, which address symptom onset during infancy and childhood and during adulthood, guide differential diagnosis on the basis of neurological or systemic features and radiological findings. Certain clinical clues, or red flags, are also taken into consideration. Because over 100 genetic disorders are known to give rise to dystonia-ataxia syndrome, entities where dystonia and ataxia are prominent and frequent features are considered first, followed by disorders where the combination is found only occasionally. It's important to recognize that dystonia and ataxia can develop either sequentially or simultaneously during the disease course. As a result, some complex phenotypic disorders can initially mimic isolated dystonia before other clinical characteristics become apparent. Moreover, many different forms of dystonia exist, with different precipitating factors and triggers. In general, the combination of dystonia and ataxia correlates with disease course or severity. Diagnostic management should include a careful clinical examination along with magnetic resonance imaging to assess for the presence of cerebellar atrophy and other distinctive features that may guide differential diagnosis. The measurement of certain biochemical markers and other parameters in peripheral blood can also facilitate diagnosis. If these tests come back negative, genetic testing to evaluate the most frequent causes of dystonia-ataxia syndrome should be explored. There are also certain circumstances in which genetic tests should be conducted to confirm a suspected diagnosis based on biochemistry. Although treatment strategies are quite varied and the management of dystonic features in particular remains difficult, the clinical approach described in the article is intended to aid clinical decision-making, which may have the added benefit of improving patient outcomes.